maze rero nanga abantu batajya bavuga ibintu shaka abantu
for the penetration
ubona buri gako ari coming from gako ari ni gako nuwahuye Jimmy nuwahuye ni wagako
ni wagako
kwati hakigenda
no wagako niho batariye
bamwirukane rero ntabwo yashobora igisirikare bana mu burekege ntabwo yashobora nagira umuntu wundi utubwira di another person like do you want me to choose ako se choosing abira ryamo ntinza harimo abahanga n'abazwa nabibonye jewe
lecture let me try
who is that
Emmanuel
try Emmanuel ni umuntu usanzwe ari wowe gerageza twumva
let's start about coordination
ubundi icyo tuvuze uravuga uti listen I want you to change your the way of answering the questions because in practical session should go faster because we have many images here. You should say because everyone X-ray uravuga uti for this X-ray, this radiograph, technically it is good or bad because of this and this and this. Okay, if it is good, say technically it is a good radiograph. If it is not good, say technically there are some issues like this and this. Okay?
Yes.
Now, to your interpretation, I have seen this and this and this.
Go ahead. Technically, this image is good because I can see the part of the chest. I mean, one part of arm and about the neck, and even I can see the costophrenic angle means that
message yanjye technically niba ari sawa uvuye sawa turabyemera ariko niba nta ikintu gihari cy'ikibazo if there is any problem in technically aba ari uvuga gusa otherwise twafata umwanya munini
technically only problem I see because there is over penetration because I can see vertebral disc. That is the problem I can see.
But that's very good. It was over penetrated, but if you see, it didn't affect much our radiograph. It didn't affect much. Ugomba kuyongeraho kubera ko uvuze ngo there is a problem twagira ngo uraza kunanirwa gukora interpretation. So ibindi byose bimeze neza?
Yes.
Can you count the posterior ribs? Count for me.
Posterior ribs.
How many are they?
Okay, let me. 1, 2, 3.
Hey, you are very slow.
4, 5, 6, 7, 8, 9, 10, 11, 12. 12.
Hey, my friend, 12 above the diaphragm. That's what I'm talking about.
No, above the diaphragm is 10. I see.
No, ndabizi ko afite imbavu 12 ariko wakuyemo se. But I'm talking about ibyo twavuze. To give it is a different inspiration. How many? 6? How many anterior nako?
Anterior. There are 7. But the one which is above the diaphragm are 6.
Yeah.
The one
above, there are 7. Even the 7th ones can cross the mid-clavicular line above the diaphragm, I think. Okay?
Yes.
Is it a female or male?
Let me see. This person is
it's a female.
Why? Don't you have breast? You man, don't you have a breast?
Breast shadow.
Oh yeah, these are breast shadows. Look,
these are
breast shadows. But
they are big.
They don't have breasts. Here I have two. How about you?
hari abagabo bagira n'abagore y'abagore.
Aha, exactly. But apparently this person himself, the person herself, the X-ray shows that the person was not big enough to have, if it was a man, to have this kind of big breasts. Sawa. Icyo nicyo twavugaho. Ugiye kureba ifoto niyo umuntu mutoya unanutse ariko the breasts are big. Ibi rero ntabwo byaba ari iby'umuhungu. It's not for a man. This was apparently this was a female patient. Okay?
Yes.
So, Emmanuel.
Oui.
So go ahead for interpretation. Ukoresha iyi system yacu ya 4 things: mediastinum, lungs, bones, and the soft tissues.
Okay. But I see that there is a high vascularization. If it is not reticular
ngo ba systematic uko twabyize nitegeko kandi n'ibindi ngombwa cyane. Yewe ndabuze ukuri ko it's very important. Be systematic. Ako tubyo biragwera. Are you from Gako, from Huye?
Huye.
Exactly, I can hear.
Yeah, Rector, about mediastinum, the heart is not enlarged. Yeah.
That's not?
It is not enlarged heart.
Washaka ko iba enlarged? Wabishimije ashaka?
No.
Kutubwira nkaho ari ikibazo.
No problem. And
so say the heart is normal in size.
Yeah, and it's normal in size. Yeah. And about in drugs, I see the problem. I see.
Anyway, oya ariko muri guta cyane none se muri mediastinum ubonye hati yonyine. Kasi uzi kuzagisi abarwayi bazapfa bose ba? Bose. Hano muzavura rwose. Uzajya birebera ko umutima ari muzima gusa wigenda mu bwete genda buri muzima agenda.
Yeah, in mediastinum nothing problem I can see.
Okay, ubundi watangiye kuvuga uti trachea
is
central,
in midline.
The mediastinum self, the size is normal. And the heart is normal in size, the configuration. Nibyo nshaka ko mujya mureba. There is urebye nta kindi, the great vessels are okay, normal.
Yeah. Then but I see that still like reticulonodula in the left.
Ugeze scan. Uvuye uje. How kusimbuka cyane ni?
In the ranks.
Uvuye ugeze.
In ranks. From mediastinum in the ranks.
Ujemo udaciye ku madirishya cyangwa ku rugi. Uciye. How can you uciye? Cyangwa ntabwo bayifashe ko ntabwo mufite ahantu mwandika. Iyo mwarimu ari kwigisha ni mwandika ni
twarabyanditse.
None se kuki ajya muri rangs ataciye ku murugi cyangwa mu dirishya? Rega mpita numva. Do you know the reason why I put this X-ray, this one? Najya numve neza if you captured the message I gave you. Cyangwa mbyihera minye mpita mbona ko mu mutwe biracyari akavuyo kenshi cyane bikabije. Because if you are not systematic ndabwiza ukuri ntabwo tuzajyana na gato. Nta nubwo muzanatsina ibizamini bigenda. Muzabisubiraho mwese. Kunesha umwanya. Kandi ubwo Manuel ni wageragezaga ubwo abandi bose bari inyuma.
Oya lecture hari abantu benshi
akwiyaminiya.
Ngabona ariko ndashaka ko Manuel arikira. Emmanuel. Please navuze yuko wirangije mediastinum uhita ureba mbere yo kujya kuri lungs ureba highlam. Ese simeze neza kandi highlam region ukareba niba. Listen, the left one is above compared to the right one. Cyane cyane ukareba niba ifite concavity yako lateral concavity ukareba ko imeze neza. That's very important. Highlam never contemplate ibyo highlam kandi imeze neza. So go to the lungs and move.
Yeah, and lungs, I see that there is in the left.
Bivuge neza. Afite ari umuntu umurezida ntabwo nakwirwa mubaza nyibyo ariko this is the first image mutangiye kwinterpreta. You are putting into your theory into practice. No ntabwo kwivuga uti the upper zone.
Yeah, upper zone is okay. But
muko nabikora gake yagiye ariko asigana no kubikisha.
Yeah, but the lower part.
Ugeze kuri utazanze upper ko duhera kuri upper zone.
Yeah, upper zone is okay. I see.
Ntabyo tubwiye ariko. The upper zone is good. Sim file. Yeah. The middle zone imezite.
He has problem in middle zone.
Yeah,
on the right. Is this vascular or it's problem? Yeah, lecturer, I see that there is like a small nodule.
You are talking about these ones, these ones. Okay. This message I didn't give you. You remember, lungs are not flat as you see them here. The orientation of pulmonary vessels, the pulmonary vessels are oriented in different directions. Some of them are, you see them on profile, oblique. Others are looking at you. Others are oriented posteriorly. Sibyo? So rero iyo ukoze x-ray ziriya central looking like nodules, they are vessels that are thin and fast. They are cut and fast. Izo ubona zirambuye, they are vessels that are thin in profile. Okay? Wabyumvise?
Yes.
When you see these small nodules like this, they are vessels, centrally they are vessels that are thin, that are cut and fast. Uramutse ubonye these small nodules ukazibona peripherally like here or peripheral, niho haba hari ikibazo. That's a problem because normally vessels you don't see them at one side. When you see them centrally, they are still vessels. At thin and fast. And when we say fast, ko bicyo cyaricyo. Nk'igiti gifite amashami mwarareba ku ruhande ari yakureba ayerekeza iwawe uyakase bigaragara gute? Uramutse uyakase bigaragara gute?
Nk'utudomo.
Exactly the same. Nicyo bimeze na nuko bigenda kuri x-ray then. Okay. Sila, can you get the message? Sila, Silak is back or not? Some examples tuzitanga mu Kinyarwanda, we give them in Kinyarwanda. That's the reason why so continue, Emmanuel. If Silak is not here, I don't know. Continue.
Nachibazo, you can use Kinyarwanda.
Hey, that's who?
Silak.
They have a wife, a Rwandan wife.
Yes.
Yes, I have a wife, a Rwandan wife.
Good. Continue, please. Emmanuel.
Yeah, the middle part of the lungs. Yeah, In the middle part of the lung is okay, and even in the lower part of the lungs, it's
Well,
okay.
don't say lower part. What do you mean? Use zones if you are not able
Zones.
to. Zone.
Yeah, the lower zone is okay. And about the bones are
Remember
also.
after it, you cannot finish to talk about the lungs without talking about the pleura. The pleura is part of the lung because it's the cover.
Yes.
It's the cover of the lung, so it's part of the lung. That's pleural space. Is it thickened? Is there pleural effusion?
Okay, lecturer, the pleura, it's okay. It's not thickened, and there is no effusion, I see. Yeah, it's okay too.
Okay.
And yeah, and
so you go to
2 bones. Yeah, the bones are okay. I didn't see any problem about bones.
Okay, but here I can comment. Please don't just we don't have time maybe, but make sure you have seen each bone. You have looked at each bone. Don't just say bones are okay.
Okay. And about soft tissues, let me talk about diaphragm. On diaphragm, I see that the left and the right are somehow equal at the level diaphragm. Yeah,
what?
I see that the diaphragm, left and right one, are almost at the same level.
Okay, but as I told you, when it's for some people, maybe because of the position, or even normally, diaphragm are not at the same level. It's not an issue unless you can see any abnormal cause. Where there is no abnormal cause of that being at the same level, please, it's a normal. Okay.
And the costophrenic angles are sharp.
Kuzigarutseho kandi ziriya zari part of the lungs. Why are you coming back? Ndashaka ko mugira iyo system. That system, please.
Okay. So
Ndashaka ko mukubita hirya no hino rwose.
Okay, I'm done because nothing abnormal I have found.
So for you, this is normal.
Yeah,
has anyone seen any abnormality? Kutatubwiye niba ari PA cyangwa AP? Is it a PA or AP?
It's PA view.
Why?
Yeah, it's a
It's
PA.
right.
Because I can see the scapula are outward, and even the heart is not enlarged, so I can see that it is PA view.
Okay, that's good. So thank you very much. You tried. Kandi ubundi usanzwe ugerageza gusubiza. I like the people who are active. Ikintu nshaka kubasaba, there's something I want you to know. Yes?
Excuse me. On the bones, on the bones, on the 11th, I think 11th rib. Is it normal on the left side?
Which one? It is. Do you want to talk about this whitish something?
Yeah.
That is spine position of soft tissue of from maybe the gastric wall and the rib itself. That can increase the density.
On the where
Please,
it is.
Always when you see something abnormal,
on the beginning of that 11th,
here
around the vertebral body,
no, it is. That is a costo. It's called how is it called? Costochondral junction. So, because it's normal. Why are you calling it abnormal? Look at the others. Is it? It's normal.
Okay, it's okay.
Costochondral junction.
Yes, yes.
So, something I want you to get from this image. Please open your eyes and see how the normal pulmonary vessels look like. Someone someone want to ask a question? No. So look at the image, the vessels. How they are smoothly oriented or obliquely oriented with smooth walls. Please. If you have this in your mind, it will help you in other X-rays to know if they are abnormal, to know if they are linear opacities or reticular or any other abnormality. Check, look, Jem, and have this image in your mind. It's a normal chest radiograph, normal pulmonary vessels, something that doesn't look like this, it's abnormal. So the next case is for Honorine Inkoramutima. Are you there, Honorine?
Yes, I'm there.
So the second case is for you. I want you to be faster, not like Emmanuel, because I have given you an example. This is your case. Interpret it very fast.
Thank you. Let's first start at the technical quality of this image. I think about centering, it's okay. And you move to the rotation. I think it's okay. There is no rotation here. And about inspiration, I'm not sure, but I see it is deep inspiration.
Why not sure? Why not being sure? Ntukajye uvuga gutyo kandi radiology ntabwo tuvuga gutyo, ijambo ntabwo tujya turikoresha.
Okay. Let me count the ribs.
Especially when it is, you can be sure here.
Yeah, it's in deep inspiration.
Why? Why? How many posterior ribs?
Okay, 1, 2, 3. It's 8. I'm seeing 8 ribs.
Honorine, eh?
Yes.
Apparently, you don't know how to count ribs then. Because here we have 10 ribs, posterior ribs, 10. I said posterior ribs, there are 10. Even 11, even the 11th is there. But I count up to this, that 10. It's just 1, 2, 3, 4, 5, 6, 7,
okay, I have
8, 9, 10, even 11th, imagine. Huh?
Yeah, I didn't count 1 and 2. I started at 3, that's why.
Ubwo si byo muri radiology bya uzi ko bagufunga. Siko wajya mabuso neza mabu tugora. Count 1 and 2, what do you mean? Siko bagufunga? Amagara rib.
Okay, about penetration.
Count for me the anterior ribs. How many are they?
Seven.
I don't know if the 7th is within. Remember the mid-clavicular line, I don't know. But it's deep inspiration, whatever it is.
Okay, the 6th one cross mid-clavicular line.
The 7th.
Yeah.
Then about you're hesitating, I don't know why. So continue.
Okay, about penetration, it is well.
It is well.
And you move to the, yeah.
Yeah, it is. Because you can see the spine faintly, not very well.
Yeah, sure.
There is no angulation.
We move to the systemic. We move to the image analysis.
Uh-huh.
About airway, I have seen that trachea is when it's not rotated or deviated to to left or right. And about, we move to the hiram. I see there is no problem at hiram. Hiram. Hyla. And also, yeah, we move to the bones.
Hey, my friend. Sasa wowe umugabo azakwirukana wa uzajya ugenderera n'abagenderera bizagenda bite? Follow my instructions. Follow my system.
Okay. Mediastinum.
Mediastinum muri bavuga nyine bavuga track yavuga nta nubwo wavuze hati ufite akusime kumbize mutabana. Sera muri kubyumva je mufite mu kibazo gikomeye tubajyane mu ntuza se babapimeza bakoreza EEG. wafashe notebook yawe ukandikamo ibyo ugomba gukurikiza ureba harimo nakubaza ukabisoma ukabigurikiza aricyo bitwaye ubu ibintu bine byakonaniye kubifata mu mutwe kwanze no gutabisoma vuba kuri mediastinum ukajya ranga uciye kuri hiram ukareba bones ukareba soft tissue ibintu bihambaye byagusaba rwose kujibagirwa vrema abantu biga medicine mu bagati kera abantu bigaga medicine bavuga ko bigaga university bakora abantu bitangaza none babaye ibyayi ba university no gufata ibintu bine byabaye iki babaye icyayi bavuga ngo babaye icyayi babaye diriwe relation sisa honorini.
Yes sir.
Gukurikirana ibyo bintu byakunaniye kuva mediastinum ukayireba ukajya kuri lungs ukajya kuri bones ukajya kuri soft tissue byakunaniye kwera vrema imbere y'abagabo n'abagore muri bari hano sikashaka kubenga bose ko bangana bose mu medicine ngo ukajya gushakira muri za SS
nta n'umwe mfitemo
ashaka kuzaza at the end of the program. Don't worry. So go ahead. Bukariro neza.
Okay. About the rank.
No, nta nubwo urarangiza icya mbere. Ntabwo watangiye.
Mediastinum.
Yes, niyo ya mbere babanza.
Nayivuze.
Ntacyo wavuze iki? Wavuze iki? Niba yavuze bisubiramo twumve.
Okay, about trachea and hiram. Trachea is very centered, there's no deviation and rotation. And also about hiram, it's okay.
Hiram ntabwo ari part of mediastinum. Juvenes.
Yes.
Anubwo muzi na anatomy. Wayo mwiga mu handi hano. Hiram ntabwo ari part of mediastinum. Ahubwo the big part of mediastinum ntabwo uri kwivugaho.
The heart.
Yes, none se urazi bya Hiram. Ubusanzwe usaba usimbuka simbuka.
Okay, at border is okay. I have seen.
Ureba border gusa se. Uko ingana se.
Okay, yes. It's okay. Site, shape, and what? Size, shape, and shadow. I think all is fine. And also shadow too. Site, size, shape, and shadow. All is fine.
Yes, even shadows are fine. Okay, so no problem. Continue.
Yeah, it's fine. Okay, we move to the ranks.
Bypassing on the hiram. Bypassing, before you go to lungs, even if hiram is not a step, but you have to talk about. Now you see one very.
Okay. We move
Okay.
to the ranks.
Fuka kuri hiram wa muswako. ko mbikubwira
Exactly,
nunabikora
nayivuga kangahe nayivuze.
wavuze gute
Navuze ko imeze neza.
imeze neza se ushatse uvuga iki n'inzobe irirabura odime
Ifite imibiri yombi.
please zo okay niki cyerekana ko imeze neza
Okay, kuri left side ifite
hayira muri cyerekana ko zimeze neza hayira
okay, iyo kuri right ibiri iyo kuri left iba ifite concave shape ku ruhande.
n'iyindi nuko ariko both
both. Iyo kuri right biri hejuru.
iyo kuri left niba hejuru wa mukobwa where is the right, where is the left?
Okay, left side ni kuyibona.
Left side nahanditse amagambo, nahanditse R or
nahanditse amagambo. Nahanditse amagambo.
Voilà, so none se kubicirika left should be up, the higher my
yeah. Yeah. We move
so
to the lungs. Okay, move to the lungs. Upper zone is okay. I'm saying that's okay. There's no problem there. In middle zone, there is no problem too. I think this is vessels, no problem there. About lower zone, above light diaphragm, there is opacity.
Which opacity? They never say that word opacity. You have to always describe which type of opacity.
Yes, please, opacity.
Ayibonye he, where is it? Kumbona je hasa. Ubuse niba lower zone ari ingiyo hasi. Niye hanu hazasa n'ahandi. If it is this region, it looks like this one. If about the vessels, they look like the same. If I don't see any opacity, no one tabasha kunyereka I don't see. Teka niba ijisho ryawe rimwe ritafite ikiba ariko it's the same. Okay, I don't sincerely speaking. When we have it is symmetrical. Nubwo ashyiraho rula uraza gusanga ahantu hose hasa n'ahandi. Everything is fine. So continue.
Okay, soft tissues.
Oya ntabwo urangiza navuze ko lungs reka mujye mwinga kuri cases zibanza. I mean uwa gatatu nibubaze ngo avuge ntaze gukora amakosa nk'ayabandi bakoze. We should learn from the history. Uko twavuze ko lungs, you cannot finish to talk about the lungs without talking about the pleural and costophrenic angles. Ntibishoboka. Kandi rwose ukurikiyeho ntiyongeye kubikora ikosa.
What else?
Utese urimo urambaza n'igiye gusubiza.
Kubona nabirangije.
Uri umuswa cyane. Aho tugende jya ahandi ushaka basi tubumve turangize. Okay?
Okay, move to the soft tissue.
Bones wazivuze. Nta kibazo.
Bones zimeze neza. Okay. Bones ndabona zimeze neza. Trachea.
Trachea muri bones ubwo. Garutse inyuma
Sorry, clavicle. Sorry, I'm sorry. Clavicle. Ribs too. Scapula. And also vertebra. Put these. And humerus. Proximal part. Okay, I think bones is over.
Soft tissues.
Yeah, we move to the soft tissues.
Mm. Moving nyine twumva uretse kutakubona.
Okay, next soft tissue. You have seen neck is okay.
Iyi foto iri kuri ntuzo yawe ni iyawe?
Wapi?
Kuyo nitwahura azakumenye kwa ngaho komeza. Next okay.
Agari yanjye.
Supraclavicular regions are okay. Axilla, chest wall, diaphragm. Yeah. So the next, this is a normal chest radiograph. Okay.
Yeah.
So witwa Ira Aline. Ira ari nta mudije witwa Ira wo kuri TV. Ira ari hehe? Aha. The next is for you. The next image is for you. Okay, this one. So try to be a bit faster. Mm-hmm. Hello. Hello, aravuga? Hello.
Ntabwo ari kuvuga.
Navuge nyine mumubwira bicaranye nawe mubwira cyo kutesha umwanya. Mana. Sukugiwe. Ntabwo hariya nta nkoni zikora mu ishuri.
I was saying that this image has a good quality.
It's an issue of network issue. If there's a network issue, ikibazo cyane ndibaza niba se atabasha kuvuga ngo tumwumve we yatwumvaga.
Ariko
Talk. Oh.
Hey guys, are you getting me?
Yes, we can hear you.
Okay. Starting with collimation. The above image has a good collimation.
Okay.
Yeah.
I agree with you.
Then
Ariko twavuze, listen to me. Twavuze ngo for technical qualities uravuga uti this chest radiograph has a good, it's good except ukavuga ikitameze neza muri technical, otherwise turatinda cyane. Niki wabonye kitameze neza technically? What's wrong technically? And always keep telling us, is it a PA or AP? That's very important, by the way, because it can change and affect the interpretation.
So, this is a PA image. And the concern with the above image is that there is over penetration.
So dusubire mu rwayi tizibiremo. Can you repeat it?
No, it's good.
So over penetration is good. Yeah. So overpenetrated is okay for you.
No,
So
I think that the overpenetration won't affect the interpretation of this image.
okay, that's good. What else? Technically, what else is wrong? What else is wrong?
Rotation.
Yeah, there is rotation
There
to which
is a
side?
rotation of to the left side.
Yeah, the right side. And again, how can you see how the part of the mediastinum, even the heart, big part of the heart has gone to the right side because of rotation. That's because of this
sure.
rotation. It has gone out on the right side. What else? And technically, the rest is okay? Was it in a good?
The less is okay. There
Is it a good inspiration?
let me count the leaves. 1, 2, 3, 4, 5.
Which one are you counting?
It's in explanation.
Which ribs are you counting?
The posterior ones.
Posterior, how many are there?
Posterior, they are only 8.
Yeah, the only so it's slightly it was not deep inspiration. Okay.
Yeah.
So okay, continue.
And moving to the mediastinum, generally there is normal size of the heart. The hilum is okay. And moving to the zones of the heart,
So
the upper
mediastinum
zone, middle, and lower,
wayirangije se. Listen to me. Have you talked about mediastinum warangije? Mediastinum ntabwo ari heart man.
Okay, about the
Yavuze mediastinum ntabwo uvuze heart rwose.
What's hilum?
About the mediastinum, Prof, the trachea is okay.
It is somehow, sometimes it is slightly deviated to the right side biragaragara ariko. Ntabwo ubona ko
As you've said before, there is a rotation to the right side. So it has
ariko iyo ugiye kwivuga ntabwo uceceka, ntabwo uvuga ngo ubwo navuze ko rotation ntabwo ningeraho ngasanga iri deviated, I will not talk about it. You have to say
okay.
It is slightly deviated to the right side, but due to rotation. Okay.
Okay.
What else, please, faster?
I was saying that the hilum is okay. And moving to the lungs, I think all the zones are okay. There are no consolidations or cavitations. They are okay. No, it's true. Yeah. I was saying that all the zones of the heart, I mean all the zones of the lungs are okay. They are okay.
Okay. Are you sure?
Yes, I'm sure, Prof.
Are you sure? What's
Yes,
this?
I am.
It's not in the lung? Isn't this in the lung?
I don't think that is a part of the lung.
Yeah. Wakurikiraga ryari? You didn't follow my lectures. You didn't follow my lectures, Ira. Apparently. Because when you say that,
I think
you
that
didn't
is
follow my lectures. Why do you say it's an apple? Why are you saying it is a nipple?
Because they are bilateral, they are on both sides of
Exactly.
the image.
That's what I wanted to hear. This is a nip. Those are nipples because they are bilateral. If there was one side,
Mm.
that, but don't. Kukivuze ngo injya ari muri lung. That's ni igitangaza. None muracyabivuga cyangwa tugusobanurire byumve. This is part of the lung posteriorly. I said, eh?
Yes, it's a part of the lung.
Komeza two.
I think I'm done.
Done is wakoze iki kintu. Nta usobanurije bones and soft tissues waziranye. Hakuze ko umurangiza vuba vuba mwirukanka vuba vuba. Warangije iki? Please, you should talk about the bones and soft tissue, whatever. This is a normal, so this is a normal chest radiograph. I just want to teach you about these nipples
Yeah, it's an
and teach you the effect of rotation to the mediastinum.
Yes.
but
Okay.
sorry, Prof.
Yeah.
I have a problem from this image. What about the clavicles? Are they normal?
They are normal. Yes, they are very normal.
Okay.
Now, in
Thank
positioning
you.
your fascia when they are taking some this image, it was a positional change.
I see.
It was position. Okay. This is another image. So anga ntabwo ngiye kubabwira ibintu byinshi. What are you seeing? Ntabwo nkomeza kubaza umuntu umwe muradutinza ntabwo twarangiza vuba. What are you seeing as abnormality? Either technical or disease. Technical. What is there wrong?
I think it is angulation.
That's very good. You see, this is the right lung is not looking as the left one. So okay? Because the left one is opaque compared to the right one. But when you see, it's not an opacity as such. It is due to rotation to technical issue. What is that technical issue? It's angulation. But now this angulation was coming from the machine itself, X-ray machine. It is what you call, if you remember, I told you about what you call Arnold Hill effect. Arnold Hill effect. Do you remember that word? Arnold Hill effect. The X-ray, when they are coming from the machine, they concentrate on one side of when they are coming out of the machine, the majority of them, they are concentrated on one side of the patient. Arnold Hill effect. It's about the settings of the machine they have to correct. When you see this now, you immediately know, this is technical. It's not a disease. Okay? Okay?
Yes.
So this, I put this slide to remind you about different type of opacities. Like this number one, which type of opacities do you think these are? This one, which type?
Patch.
wowe nta nubwo bakuvuza ngo uzakire ngo paci gutese kandi paci bimeze itese nuko waguha ibinini bingana gute ntiwakira wowe. Type of the opacities here, is it interstitial or alveolar? Interstitial first. Which type now? Because interstitial twazibonye izo arizo.
Reticular.
Exactly. These are reticular. This is reticular opacification of the lungs. Reticular. Okay? Twagiye. How about here? The second one here?
Nodular.
Exactly. These are nodular opacification of the lungs. In the middle. Eh?
Reticular.
Look very well. This one. But my friend Silak, you are not answering today. What's wrong? Silak. Huh?
ibyo yarazi byararangiye.
Byararangiye. Silak.
Baramubeshyeye ko atari kubyumva.
Ari yes.
Ari kumwe n'umuntu nyine.
Oh, okay, so twikomereze bana. Which type of opacity is I?
I think it's alveolar. No.
This interstitial opacity is which type?
Micronodular.
The confusion kuri iki kintu. To recognize opacities. These ones. It is micro. Okay, it is like this one, but these are micro, small one. Micronodular, or these are nodular. Micronodular, nodular. Okay.
Yeah,
How about this? How about this? This one.
Ifoto ntabwo iri kugaragara neza.
No, iragaragara neza cyane niba tugeze ko kutese. Cyeka nawe ikibazo cyanyu ari kugira iragaragara cyane.
Connection nicyo kibazo.
Eh? That's the problem with internet.
But it is reticulonodular opacities.
Exactly. They are reticular and the nodules. Reticular nodular opacities. Okay? The first one is reticular, but this one is reticular nodular. That's good. And the last one?
dusobanure ko zimeze kimwe ngo twese tutandukanira.
Bizabafata igihe imyaka di komeza ya nyuma. The last one please.
Ako bijya gusa.
Wadufashije
sa kugira ngo urasanga namwe muragenda gusa. Namwe murenda gusa di. The last one please.
Ntabwo dusa.
But the last one is the last one is their masses. These are masses, reticulonodular, micronodular, nodular, and reticular. Okay?
Reticular, yes.
Dutandukanyiriza basi bwa nyuma.
So, cyose simaze kugikora. Kanongere. Reticular, okay? Nodular.
Itandukanyiriza rya reticular na reticulonodular ryo rigoye.
Understand what? Understand what? None se iyo tuvuze reticular nodular umvamo iki? Umvamo reticular first hakazamo na nodules. Hari ikindi? Wavuga reticular gusa ikaba ari reticular nta nodules zihari.
Ariko iriya ya mbere
ibibazo birasa, ibintu birasa.
Ntabwo bisa muze gufata umwanya mu birebe neza.
Ukuntu mbizi ngewe nzi ko
mwitonze muzasanga ko bitandukanye.
Lecture. Ngewe ukuntu mbizi reticular tumeze nk'uturongo. Noneho nodular
n'ubundi ngo uturongo. Listen. N'ubundi urebye kuri ya mbere ni uturongo gusa tugiye tunyuranamo. Okay? Nta nodules n'uturongo tunyuranamo gusa.
Lecture utunodules
bizaza. Harimo wareba kuri iyi ngiyi.
Fabrice afite matsiyeri.
Listen to me. Iyi ngiyi ugasanga harimo umurongo akabamo n'utunodules. Listen, ko nafata umutwe ngo ngisature imbiteremo n'akazi kanyu mugumana n'ibyo mwabonye. Okay?
Ukomeze.
Uwo ninjye bari kubwira pa.
Uwo ninjye bari kubwira.
Twikomereze
Twikomereze
ati ibindi bizagenda biza. ndashaka umuntu witwa Ntuza,
komereze kuri iyo
umuntu witwa
collapse.
Somana Olivier ni ari yego
arahari
nshaka
rwose
kuvugana
nazi. Afite itsinda.
Somana Olivier
lecture.
Somana Olivier niwe nshaka. Olivier Somana ariko atavuga.
nawe wasanga ari kumwe n'umuntu.
Ni nka Sirake, niba ari Sirake.
Icyo abantu bari gukora nibyo bihe bigezweho.
Sasa rero niba abantu batari gusubiza igihe mbabajije ni akazi kabo, njye ntabwo byitayeho. Let me yes abashaka bakurikira n'abadashaka ko nzi ko bizabagora. So tell me the pathology here. Abashaka bakurikire basubize, abadashaka babyore. Ntabwo njya kubaza umuntu n'umwe umaze kuntera umujinya. Umuntu mukuru wamubaza kugira ngo amufashe ntasubize.
Collapse.
Collapse.
Why?
Ni collapse man.
Tell me why. Tell me why.
Right lung collapse.
Mbwira impamvu rero. Try to
Deviation of trachea.
Trachea is deviated to the right.
If you have that's not explanation. Because can be deviated by pushing, pulled or pushed.
It is pulled.
Pulled is a koko ikiganza wanki kurura. This is some haramaboko oyikurura ibona. You should explain here. Maybe you are right, but explain so that I understand that.
It is pneumothorax.
There is homogeneous opacity on the right trunk field.
Avuga umuntu umwe, okay? Tell me, there is homogeneous opacification on the right hemithorax, okay? So?
And the trachea is deviated to the right.
To the same side.
This is consistent. Yeah. This is consistent with the lung collapse, meaning that the right lung is not being aerated.
Okay, that's very good, because even in the description, you should have by homogeneous opacification the right hemithorax, and now if it is fluid by the trachea is deviated towards the same side. And hari cyaga gatatu tambwiye ko bibazo byanyu nkunda kubaza ngo tell me the findings. You should even add why
also there is a shift of mediastinum,
especially the trachea, and why the left lung is too dark like this. What do you think?
It's hyperinflated.
Yeah, compensatory hyperinflation. Compensatory hyperinflation. Okay, so this is the right lung collapse. Okay?
Yes.
Mwabyumvise?
Yes.
Ababyumvise na nibyo birahagi. Nubwo haboneka umuntu wabyumvise ukurikira nta kibazo. Okay? What do you think here?
I think it is collapse of left lower lobe of lung.
Ninde ubivuze? Sasa radiology duhera ku byo tubona, haba no gupfa guhumiriza ukavuga ikintu. Ubwo si ibyo byakora busubivanye koko. Hari umuntu ubona ikindi kintu cyafu
fluid air fluid cavity.
Byakora busubivanye koko. Ntabwo ndi kukumva je.
In the right lung there is heterogeneous opacities. In the right lung there is heterogeneous opacities.
Can't you see that there is a cavity here, smooth wall with air fluid level. There is another one nearby, smooth wall and air fluid level. There is another one here, big one, cavity with fluid, air fluid level. There is even another one here with air fluid level. Can you see these cavities? This is lateral view, where you can see those cavities like this one with air fluid level. There is another one. There is another one. Can you see those cavities?
Yes.
That is the issue. The rest is okay. The rest of the lungs, they don't have any problem. So there are multiple and bilateral cavities that show smooth walls with internal air fluid levels. This can be, you remember, the differential diagnosis of cavities like this multiple. Their main differentials either staphylococcal pneumonia or emboli, septic
Lung
emboli.
abscess. What about lung abscess?
Abscess ntabwo it's possibly called multiple and bilateral like this. Less likely. There are multiple and bilateral. Staphylococcal pneumonia cyangwa se septic emboli. Okay? Twagiye abakurikirana bumvise igipfa kubona umuntu umwe kubaza akakurikira. What do you think here? Mujye mubanza mwitegereze neza technically murebe niba everything is fine, hanyuma mubone kujya kuri interpretation. And you have ntukavuge diagnostic udafite facts. Niba uzi kutabona fact, don't talk. Nuvuga nko kubaza ngo how ukabura icyo uvuga vraiment no kuri kure yanjye nabundi machine yanjye nshaka kumena machine yanjye yani imbere yanjye.
On the right side, there is homogeneous opacities with silhouette sign.
Right side?
Left side. I'm sorry, left side.
Left side.
There is what?
Homogeneous opacity.
Listen. Oya, buretse gatoyi. Kugira ngo twavanse neza bigende neza, urumva? Ndabaha akanya mu birebe umbwire diagnosis, giye nkubaze unsobanurire impamvu yifisemo. Nta kindi. Ntumbwire rwose ngo opacity idafite akamaro nta kibimari. Mbwira this is this. Genda tegereza ko umuntu afite iki n'iki kubera ko hari ibi n'ibi nta kindi.
I think that there is a left lung collapse.
Ntabwo bivuze ko mbyemeye ariko tell me the reason.
The reason is that we see the homogeneous opacity or consolidation is in the left lung.
Don't use consolidation. Monsieur.
Yes.
Ntuvuge consolidation utazi. Consolidation it is a diagnostic term, ntabwo ari descriptive term. Descriptive kuko wavuze consolidation deja waranje kuvuga yuko ntabwo kiri collapse, it's something else.
Yes. Yes. There is also shift of mediastinum on the, especially trachea, slightly on the left side. Also, we have the reduce of the volume of the lung. As you see, air is concentrated on only the right side. Yeah, those are
So what do you think?
All of those reasons can show us that there is a left lung collapse.
Me, I think that it is a fusion.
Why? Tell me.
There is a fusion in the left lung.
I like that. What's your name, by the way?
Yeah.
What name?
My name is Divine.
Your name?
My name is Divine.
buri gihe niwo ugerageza gusubiza buri gihe kenshi.
Yego. Yeah.
Ya kuko ijwi ndumva nararyumvise umukobwa umwe ugiye uvuga abandi bose ntawe uvuga ni wowe wenyine uvuga. anywa kahe
Amstel
coach.
Nkoreze bitanu gusa bari ibimenyetso.
Asakaze nkamugurira. So ratambwiye tell me the reasons.
Yeah, there is a fusion in the left lung. This leads to the right lung takeover, and this due to the filling of the right lung, this push the mediastinal content, including the heart, to the left side. That's what I can see there.
None se wowe pleural effusion irahagana he? On which side?
In the left side. Effusion take place in the left
None se
side.
iri left side noneho uvuze ibintu byinshi ntazi ibyo uvuze ibintu byinshi bivangavanze. Can you repeat please?
The left side have the effusion. This leads to the opacity. And then the right side there is air there. And due to that, the right side lung is taking over the function of the both lungs. This leads to the mediastinal shift toward the left side.
Sir, if it was an effusion, it
the
would
air
push
can push
the
the water.
mediastinum and the...
Oh yeah, no. Ari air na water what will push ushize umwuka no mwishashi n'amazi icyahungisha kinini ki.
Siraka yizi.
Divin, oh yeah, it is easy. Hagati y'umwuka n'amazi cyakwirukana kinini.
Amazi akubihera.
I think that the water can push the
Yes, na dense. Yes, amazi ni yasunika umwuka, I think. Ntabwo umwuka asunika amazi rwose.
Yes.
I mean, ndashaka kuvuga muri physics bisanzwe. Ntabwo profession ingana gutya niba ari profession ntabwo umwuka uri mu gihaha cy'iburyo wari wagombye gutuma mediastinal shifting to the same side of the flow effusion. It can't happen.
It's not the flow effusion.
Divine, listen to me. Twabivuzeho cyane ndashaka ko Divine abyumva. Listen. Listen how you describe this. There is homogeneous supercification of the left hemithorax with slight deviation of the trachea to the same side of the left side. Okay? With with elevation of the hemidiaphragm. Can you see elevation?
Somehow.
Because this is somehow reba iburyo neri ibumoso hano uri hejuru iriya because this is gastric bubble. Look, it's up.
Yeah, birabaye elevation.
It is elevated cyane. This is a
Yeah,
very
there
important
is a
sign.
pull.
So those signs are in favor. They are in favor of left lung collapse. Even ntabwo pre-effusion yaba ihari ngo mediastinum yongere ije ku the same side ntibishoboka. It can't happen. Again, let me ask you a question for you to understand then, for everybody. Why the opacity here is different from that one here? If the left lung is collapsed, who can answer? If the left lung collapsed, why here the density is different from here?
Left lung, I think the reason is because the lung doesn't collapse totally.
So there are some air still entering the left lung.
Yes, especially on the upper zone.
There is still some air. When you look at the radiology, who is this person? Sasa umuntu akabaganiza wanamumenyere n'ukuri. Umuntu no mu ishuri akavuza radio gutyo. That's very stupid, man. Hari ibintu nimwe ntamera rwose. Kana mujye mumva rwose. We can talk, you can joke, but joking with this kind of muri lecture ukashyiraho radio or something. This is too much. Ngwese mbonye wari we I can make oya hari gukabya.
abantu
So there's still
basonetse
some ariko basohoka batasohoka they are stupid enough. That's stupidity kuri umuntu kugira ngo azayikire no kujya kwicuza kwa padiri. Cyangwa akajya kwatura kwa pasiteri sibyo urabona still nubwo lungs iri collapsed rero gushaka kuba not completely collapsed ku buryo there are still some air that is entering the left lung. Niyo mpamvu ubona the density here is different from this part of the lung, okay, but the lung is collapsed. The next image, what are you seeing? Abnormality, tell me. Abashaka kwiga mwikurikira data mwige, abadashaka nzababona mu kizamini koma mpibereye ndizira nkagikurikira. Mbaza why not? Nkunda ibibazo.
Ni gute nshobora gutandukanya pleural effusion na lung collapse?
Ariko mukagira imana maze rero ikintu cyarangira online teaching tekereza ko harimo na effect ya network itameze neza. I think so. Ushobora kuba ari ibintu mvuga bamwe ntibabyumve neza cyangwa se namwe mukaba murangaye mutari gukurikira.
Tuba dukurikiye ubwo ari igihe tutabyumva neza.
Nk'ubu ibyo mbajije nibyo ndangije kuvuga nyine.
Nategereje kubyumva neza muzanabyumvira nategereje.
I can help him.
Rata help him please.
Lecture said that kugira ngo utandukanye pleural effusion na collapse isanzwe nuko pleural effusion haba habaye accumulation ya fluid ariho yatanze urugero rw'amazi azasunika mediastinum shifting ijya kuri opposite side, ariko uri kubona ko kuri no diagram dufite nta shift ya mediastinum kuri opposite side yabayeho.
It is on the same side of as opacity.
Yes.
Iyo ni ikimenyetso kigaragaza ko hari volume loss, collapse.
Exactly.
Kubera ko the mediastinal shift cyangwa the diaphragm.
Lecture, you have to speak in English, please.
That is Sirak.
Yes, that's Sirak.
Sirak, you are not there. What are you doing?
Yeah,
the whole day from morning to just now. You have just said.
No, I was present, but my connection is weak, so sometimes it gets cut.
Oh, sorry. So I was saying, when you see an opacity somewhere in each of one of the lungs, you have to follow to see for you to tell it is collapse or pleural effusion or a mass. It can even a huge mass in the lung. You should follow the mediastinum. Is it deviated to opposite side or the same side? If it is the same side, it means there is volume loss, and volume loss means collapse. If it is deviated to opposite side, it means there is either fluid pushing or any tumor mass pushing. That's how we differentiate them. Like in this case, there is homogeneous opacity of the left hemithorax, and the trachea is slightly deviated to the same side, meaning there is volume loss. This is collapse. Okay? The same as here. There is homogeneous opacification here on the right side, but the trachea is deviated to the same side. This is collapse. Okay? Is it clear? Is it clear?
Yes.
How about this one? Who can answer the question? What's the problem here? What's the problem here?
I can see the cavity on upper right.
On which? Where? Where is the cavity?
Where?
Upper lobe of the right lung.
Listen, when you see any opacity, when you see any opacity, always check the margin of that opacity. Like now you are creating the opacities yourself. This is the apex. This is the first rib, my friend. This is a normal angle of the first rib limiting it. The same as here. If you follow the first, it is the same as this one. But contrary, what we see, there is an enlargement of this superior mediastinum. Can you see that widening? As if there is a mass here. There is widening of this superior mediastinum. It's big. That's number one. Number two, they are linear opacity. It is at the base of the right lung. Can you see them? Can you see
Yes,
these
of
linear
course.
opacities? They are not vessels. I've never seen vessels being oriented this way.
Yeah.
Number three, there is also another linear opacity here. And number four, there is now airspace opacity here. This opacity is not symmetrical. As you compare the lower zone, this is not normal. So, what do you think these are? These linear opacities?
I think that it's like a segmental or subsegmental atelectasis.
Oh, that's very good. I am very happy. How about this? How about this? Airspace opacity, how do you, without clinical history, how do you call it?
Consolidation.
Consolidation, that's it. So even if it is very simple, maybe mediastinous or lymphadenopathy, when I have this kind of CT, X-ray, I will just request CT to see what's going on in the mediastinum. Is it a mass? Is it lymph node? Is it what's going on there? But others, these are subsegmental atelectatic changes, and this is consolidation. Nachin. Radiology is straightforward and having you go check around. What do you think here? What do you think here? It's very simple. This one is simple. It's an AP chest radiograph. See the scapula. The collimation was not that good, but it's neither bad. It's somehow underpenetrated film because of the spine cannot be seen. But otherwise, I can still interpret. What are you seeing now as abnormality? Divine, what are you seeing?
I can see that interstitial shadowing. Interstitial opacity.
Interstitial opacity.
Yes.
Yeah, which one? Which type?
If it is not my connection, I can see that there is reticulars.
If you have
opacity.
It is
reticular nodular. There is some nodules.
Network can
It is
change
nodular.
the quality of the image.
It is nodular opacities.
Which nodules? Which nodules?
It's micronodular.
Micronodular.
Exactly. Micronodular opacification. This maybe it was the miliary TB. Micronodular opacification of both lungs. Abantu bakumbesha network aho marambesha kandi bazi ko bari kubesha. Network ntabwo igabanya quality ahubwo network ntabwo wabona na image ahubwo.
Lecture, but even though we are saying it's micronodular, how can we confirm that it's miliarity? Because micronodular can be
something else.
Be something else.
Exactly. Hazamo clinical you have to consider the clinical presentation of the patient.
Yes.
And even
if-
lab tests.
Yeah. Then if you go direct and you say it's miliary TB, it's like a bias because you know the
I
source
know
of
the exactly. I know the patient.
Yes. Which
I
is
was
not
just
good.
telling you. I was informing you. Huh?
Clear.
I was informing you that there was miliary TB. I know the case.
Yes.
Can it be something else? Yeah. Aha, we go. What do you think? What do you think?
Yeah, I think that it's a metastasis of the cancer
Oh
because
yeah. No. What are you seeing first?
Lecturer, there is
Cardiomegaly.
micronedron.
And even
Start by the mediastinum.
Even the technical qualities.
Technical qualities is may be bad because they have overcollimated. Overcollimated, they have gone far. It is not good to overcollimate. But technically, it's not bad at all. It's not bad.
Yes.
In general, it's not bad.
About inspiration.
But mediastinum, what are you seeing? First of all, the
it's
shape is not good. The heart is
There
big.
is a cardiomegaly.
Yes.
Enough. And after that cardiomegaly, we have that patch. Now, these are alveolar opacities now.
Yes.
Alveolar and some on the left lung, you can even see some lenticular or nodular opacities. But
Yes.
in most generally, they are alveolar airspace opacities. So because there is a cardiomegaly with these airspace opacities bilaterally and symmetrical, this is now cardiac congestive heart failure with pulmonary edema. If there is a cardiomegaly and you have bilateral airspace opacities, the first thing that can come into your mind is conjunctive heart failure with pulmonary edema. Okay? And the shape of the heart can tell you which type of heart disease, like this globular shape. When you say globular shape like this, in most of the cases, it's due to pericardial effusion. Because of this shape. I know this was pericardial effusion, now causing congestive heart, it's like a heart failure and pulmonary edema. Okay, is it clear? I go to the next one.
Yes, it's clear.
That's good. Some people are following. I like it. Here, technically, it's not good because it's the first thing you have to see. It's under-penetrated. You can't see the spine through the heart shadow. You can't see it. Okay, that's one. Secondly, we even in the peripheral part of the lungs, you can't see them because of under-penetration. Okay, but mediastinum now as interpretation, the mediastinum, I can see widening of the superior and the middle mediastinum. You can ask yourself, is it aortic aneurysm or is it lymphadenopathy? If you see the ascending aorta here, even the ascending aorta is big, it can be aortic aneurysm because is it in the continuation with the descending aorta? You have to follow either aortic aneurysm or mediastinal lymphadenopathy or mediastinal mass. So let me ask you, if you are thinking that way, what is the next step? What are you going to do?
You request.
What are you going to do? You are going to request a lateral view.
Yes. No.
Exactly. Yes, that's a good answer. If you request a lateral view, you remember on lateral view, the aorta, the thoracic aorta is very well seen. You know that confusion of being mediastinal mass or an aortic aneurysm will be removed. You will know that it's aortic related mass or it is mediastinal. So the next step you have to do is doing a lateral view. Okay? Okay?
Yes.
Aha. So this is another chest radiograph. Immediately, technically, it's very good, very well done. And you will by seeing this, can you see this calling like artifact or metal something metal? It's like wires. Mediastinal wires, it means this they have done a heart surgery. Heart surgery. When you see this in the mediastinum, superimposed with the heart, there is a history of heart surgery. But I want someone to check now, analyze systematically, check the mediastinum, check the vessels, check the great vessels of the mediastinum, ascending, aortic arch, descending, the heart size, the lungs and hilum, and tell me what you see as abnormality. Anything?
Lecturer, nta kintu ndi kubona njye cy'ikibazo.
Muracyari abana muri radiology.
Lecturer.
Nta wundi muntu wabonye ikintu.
Except zone.
Kuri aortic
Lecturer. Lecturer. There is a Seir sign.
A Seir sign. Where is it?
Here, there is the opacity over the heart.
That's what you call. It's not Seir. Seir, remember, it is a triangular. It has a triangular shape. But I appreciate your eyes. Look, when you check the mediastinum, everything is fine. Trachea is okay, central. The aortic arch, I can follow it. This is the descending aorta. But by there, you miss, you can't even follow it. It is this one. The descending aorta is continuous with this superimposed opacity. Okay? Can you see it?
Yes.
This is the heart, but through the heart shadow, we have another opacity. And when that opacity is continuous with the descending aorta.
Oh.
So what is
I thought
this?
it was
What do you think this is? What do you think this is as pathology?
I think it's an aneurysm.
Yes, this is descending aortic aneurysm. Ndio ndashaka impamvu nashyizemo ndagira ngo mbigishe how to look. Listen, radiology is about being detailed. You go into details, you follow everything, you don't just overlook. You never, in radiology, you don't overlook. Kugeza n'ubu ngubu iyo ndi kureba x-ray, when I'm examining x-ray, even if I do it very fast, but I make sure I have been systematic and I have checked everything in details, not just overlooking and say, it's okay. Like when I'm looking at chest x-ray, I follow each vessel. I say, descending aorta, there's something here. And even when I'm looking at the chest, at cardiac shadow, I say, is it homogeneous? Why is it double shadow, the heart? Okay. And that double shadow, I follow it and say, something. So this was a case of thoracic descending aortic aneurysm. Okay. You go. Another very important, very interesting case. Check technical. Yeah. And the rest tell me the approach is mediastinum. Check if there is any problem. The hilum, the lungs into zones. Check the bones and soft tissue and tell me. Abantu biga ko ariko baracyahari?
Yes.
Yes, lecture.
Okay, so sinjya mashe kwatandukanye ariko nanyize ngo babatwaye muri
Lecturer, I have seen something on the left lower zone of the lung.
Which one?
Yeah.
This one. You mean this? You mean this?
Yes.
No, check always when you see. I have given you an advice. When you see something wrong for you, always check on another side if there isn't. But if you check here, it is still there. On the another side, there is the same thing, the same opacity as you see on the left side. So what do you think this is? What do you think these are?
Breast shadow.
This is a man with the breast shadow. This is a breast shadow for a man. Okay. So what else?
What does it
Anything?
mean?
Is the mediastinum okay?
No.
Is it double shadow?
Yes.
Ndabizi ibingibi nta mwabivumbura. First of all, uramutse ubonye gutya, what else to do? What can you do?
Lateral view.
Lateral view will tell you more, but before even go to lateral view, this is the heart. Listen, this is the margin of the heart. Here. And to go, this is the heart. But my question is, what do you think this is now? This is another remaining structure. Because the margin of the heart is this. With the descending aorta, the aortic arch, and come. This is the margin of the heart. No. Remember, physically, radiology and physics, they never separate. How fluid look like on X-ray. If it is pericardial effusion, it will be white like the heart. You can't differentiate it from the heart. If it is really fluid, pericardial effusion, it will have the same density as the rest of the heart. Okay?
What about the pleural thickening?
Which plural is that? Medias, okay, yeah, it is plural. But for information, this is a dilated esophagus. The esophagus is coming from there and up to this, it's big this way. Big. Dilated esophagus, what you call achalasia. Achalasia. The knowledge, the information I want to give you is from the chest radiograph. You can diagnose esophageal diseases, especially achalasia.
ariko kuri level yacu ntitwabimenya pe.
Ariko nyine erega ndababwira nyine amakuru ntabwo ndi kugira ngo mubinsubize. I wanted just by asking you questions, I want you to use your brain a bit, and now I tell you something and you learn. Hakin. So next time when you see something like this, next time when you see something like this, you will have you say, why not esophageal this something? It's esophageal dilatation, as you saw another day. Okay.
Yeah, exactly.
So this is another case. Technically, not bad. So it is interpretable. So mediastinum, I can see the superior mediastinum is normal in size. The trachea is central of the main bronchi here and there. The heart is normal in size. Going to the lungs, upper zone is all okay. The middle zone, there is a problem. What is that problem?
Left lung mass.
Maybe it's a mass.
Madam.
Mass.
Kuchiva maybe oya wundi listen. Nubwo ndi kubihutisha kwa kudafite umwanya, but we start by describing, and after description you are confident, you can be confident and say this is a mass because of this and that and that. Okay? Ariko ijambo rya maybe ntabwo muri radiology turikoresha kuko uvuze nkaho urubaye mupfumu, I mean uvuze ibintu utabonye udafitiye n'igihamya. In radiology tuvuga ibintu dufitiye gihamya, dufitiye facts. Kuko iyo mvuze ikintu ukambaza ngo kubera iki, ndabwira ngo kubera izi mpamvu izi neza bisobanutse. Ariko so tell me why you think this that to be a mass.
Lecture, I think it has a good margin, and yeah, I can see the
small margins,
the margin,
and it is homogeneous. Yes. It's round.
Yeah.
The shape.
With no air fluid level. With
no air fluid, it's homogeneous. Okay. And by looking, if that those facts, this most likely it is a mass. It is a left hilar mass. So what can it be? Ubwo rero hazamo medicine nyine, buriya niyo mpamvu medicine radiologist aba ari medical doctor. Bavuga ubundi which mass can be there? It can be either lymphadenopathy, that's very good. Number 2,
metastasis or cancer.
It doesn't do cancer with this smoothness, this smooth wall. I don't think so. But have you ever heard about bronchogenic cyst? Bronchogenic cyst.
Yeah, cyst. Yeah.
Bronchogenic cyst. Have you ever heard about them? Ega nantuza na medicine ya general medicine yanyu nyine ntabwo iraba nyinshi cyane. I understand you. Na difference ntabwo zahita ziza bitayibaza none no kugarukira kuri masse gusa nta kindi. Ariko ubundi that is also the location the location of muracyari batumbaye muri medicine in general. You still
nibwo tugitangira clinical.
Urumva ntabwo muri ahubwo iyi radiology ubu ntabwo yagombye kuza mu wa 3, yagombye kuza mu wa 4 cyangwa even mu wa 5. Mwarakoze rotations. Kuko ibu ntabwo ari y'abana batoya radiology, by'abakuru.
Twabaye bakuru.
wano ukuri ariko nivyo niyo abakuru mu medicine kwa niyo abakuru bamaze kumenya bafite clinical medicine on hands. Okay?
nshobora kuba narayobye.
Ukukora iki? Gukora iki? Can I continue? So this is a mass for sure, and it's whether lymphadenopathy but it's too big to be a lymph node, most likely bronchogenic cyst. Okay. Look at this. Look at it. Follow the instructions. Check everything and tell me.
It's massive pleural effusion.
Look very well. Why do you call it massive pleural effusion? Hello?
Yes, lecturer.
Hello? Why do
Hello.
you call it massive pleural effusion? Remember, deviation of the trachea is a second, it's a direct sign of something else. Start by
Okay.
that something else.
Okay, there is a homogeneous opacity of the left hemidiaphragm with
Left hemithorax.
yeah, homogeneous opacity with tracheal deviation to the opposite side.
And what
Which
trachea
is
deviation? Even the mediastinum. Look, this is the part of the heart. This.
yeah. So it's likely to be pleural effusion.
It's likely to be something that's pushing.
Yeah.
Okay. But my question, I appreciate your analysis, but my question is this: can fluid normally in the pleural space, the more how do you call it? The upper part of the fluid collection in the pleural space should be on lateral aspect. Okay, remember the meniscus sign. It should be on the on lateral aspect. So meaning the most upper part of the fluid collection should be on the lateral aspect, somewhere there. But this one, it has gone more medially. The upper part is the medial aspect. This is not how fluid can collect in the pleural space. Have you missed it? What's wrong with what's happening here? Tell me why, if it is pleural effusion, what is happening here?
There are still some air in the upper zone of the lung.
Hello? Can you hear me?
Yes.
Yes.
What is happening there? That's the question you should ask yourself before you decide. This is not a fashion.
There is somewhere in the lung.
Upper
zone.
So now start criticizes yourself, your opinion, and say, the fluid cannot collect in the flow space that way. It can't. Because if it is fluid, I should have seen the more opacity, the upper part of fluid there, and maybe the lower part and this shape. Okay? But lying on the medial like this. So it is more of a tumor, a mass, a tumor than fluid collection. And this part of the lung is the collapsed lung. Maybe the part of the lung that is collapsed by the tumor. Because it looks like the shape and leaving, sparing this part of the lung, it's not the fashion the fluid can collect in the flow space. So most likely it looks like a mass, a tumor in the left lung, pushing the mediastinum to the right side, to the left side, right side, I mean. Okay?
Okay, understandable.
Understandable, like it. One person, if someone understand, so I am happy and they go.
Excuse me, come back a little bit.
Yeah. I'm back.
Maybe it's a connection, but you don't get it a little bit. You can restate it.
Can you tell them?
Okay,
Yes, I
the
can.
reason because it's not a pleural effusion. You see that the opacity is it's going superiorly and medially. If we have effusion, this shape could start in periphery of the lung.
You could start by there.
Yeah.
It could feel, okay, the fluid in the flow space could feel the lateral aspect of the lung before it goes to medial. That's the fashion how fluid collects in the flow space. It
Yes.
feels first the lateral aspect of the lung
And then
before it goes to medial. Okay?
Yes. Yes.
But here it is the opposite. Here it has gone more medially than laterally. That's not fluid. In the fluid cannot collect that way.
Then we can say that it's a complete obstruction of some of the lobes of the lung.
Which one?
You see that it's the lower one, the lower left lung.
bagufunga nta mabusi iri hafi yanyu aho ngaho urihuye bahita bagufunga duhamagare n'ibyo hamagare tugufate urahagana wamba umupira umeze gute w'umutuku because listen to me, because impamvu bagufunga ntabwo volume loss yakusunika mediastinum my friend, akije ndabisubiramo kugeza ryari kanitsi ubu ari igihano cyo gufungirwa mageragere
imyaka ingahe
we ni icumi wenda bagabanya bakagera kuri 7
yambaye ikote ry'abafundi
none ubu ni iki
niba bisa ubururu niba bisa ubururu n'ibyo
navuze yuko
icyuma cyangwa amazi
icyuma
iri gufasha mediastinum
murakoze bazavuga
ubutaha ntibagufunga n'akazi kawe ntongere gukora ikosa what about ya
lung collapse.
Ni divine? Is it divine? Ninde uvuze? Abantu rero bataba confident nabo baranyobeye. Ubu wavuze ko ari wowe ko wasanga banagerageje.
Ni divine wari uvuze. Ni divine.
Ko atinye kuvuga ko ari we.
Ego ni jewe.
So why do you say which lung kwanza? Lung collapse utamenya niba ari zose.
lung collapse.
Akufite network itameze neza cyangwa ntuza yawe yo microphone ntabwo imeze neza.
ari kuvugira kure pe.
Egera.
It is the left lung collapse.
Aha, why then? Tubwire twumve rero. Aho niho dushaka kumva neza.
Due to that mediastinal shift toward the left lung, there is feeling of the left lung. It is not good. That's why they push the mediastinal content to the left side. There is loss of
kuki amagambo yo gupushinga no gupuringa, you don't differentiate pulling and pushing, icyo bivuze?
due to that there is no air in the left side, the mediastinal content will be pulled toward that side.
It's pulled. Pushed. It's pushed. Ntabwo muzi kubitandukanya?
It's pushed.
Sinzi ko pushed by what?
By the hyperinflation of the right lung.
Listen to me. Hyperinflation doesn't push. It doesn't have that power to push. Unless it's something else, but hyperinflation is something that is passive. Something that is passive cannot have power to push the mediastinum. It can't happen.
Yes. I have another suggestion. It seems like it's a heterogeneous opacity in the left lung, which can be due to there is the movement of the left diaphragm. There is upward movement of left diaphragm. Elevation, yes. There is also a little bit deviation of the trachea around the clavicle. You can see a little bit deviation of the trachea to the left side, which can.
Let me challenge you.
Yes.
Between this left lung.
Yes.
And the right one, which one is normal?
Lecture. The right lung is pathological because it has pneumothorax.
Let me see. Let me hear. Silak, tell me.
Yes, there is a pneumothorax on the right lung that is pushing all the mediastinum.
Exactly. And how do you diagnose pneumothorax? When you see a part of the lung that is too dark like this, with no vascular markings at all. No vascular. If you check, let me compare with this. This is also this lung is too dark. Okay. But if you look at this lung, there are some vascular markings.
Yes.
This is not pneumothorax, but here, no vascular markings at all.
Exactly.
This is a sign of pneumothorax. Sulcus sign. When the cosophrenic angle is too deep, it's called deep sulcus sign. Also another sign of pneumothorax. And now that pneumothorax, because it's not active, like lung hyperinflation, it's pushing the mediastinum to another side. And even the left lung is somehow compressed by the mediastinum. Normal pneumothorax, it is what you call tension in pneumothorax. Tension in pneumothorax because it is other structures. It has caused some mass effect, pushing other normal structures. But it's called tension in pneumothorax. When you see this one, don't even send the patient to the doctor to wait. Just put a needle, because the patient can die in few seconds or few minutes. Tension.
What is the lung?
Okay. So namugombe cyane. So how about this? Can you try this one? Try and tell me. Reason why I use that divine.
Opacity of the left lung. And so far as tracking
Sorry?
Nari muzaho tegereje ko akubwira iteka ryo. Nubwo uzaba uri wenyine uzabangurije ko Imana imbwira tu. Ntabwo uzajya wiyizera
there is trachea deviation to the side of opacity. And even the heart, the mediastinal content deviates to the side of the opacity.
Yes.
About the blood vessels of the right lower lobe,
Well, those are normal. Those are, there is right lung hyperinflation, compensatory hyperinflation. Okay, so
there are yes. I can
hari umuntu wigeze kubisobanura na kare niyongera asobanure. Can you explain please? One Emmanuel sinzi wabisobanuye kare.
Yes, I can explain it for him. Nk'aha ngaha kuri ino kesi urabona yuko habayeho puringi. Niyo ngo track ya yamuvinze igana cyangwa se igana ku giti cyabaye affected. Bitandukanye n'uko haba habayeho wenda nka kesi twabonye ya tumor yo ishobora gupushinga ino kesi twabonye ishobora gupushinga track ya cyangwa mediastinum ikajya kuri side itabaye affected. Nuko twabibonye ndakeka bisobanukiwe.
Nuko bivuze wihuta, when first of all you should choose which part of the lung is affected. Is it left or right first? In terms of opacity, which one is affected? Like this one was equal to the left one, but that left part is pushing the mediastinum.
Yeah,
that cannot be a collapse. Collapse won't it reduce the volume. It should normally collapse should pull, not push.
aho niho nashakaga.
wanyuzwe.
None se lecture iyi kesi yindi ibanziriza iyi ngiyi iriho iriya
this one
iyi ngiyi, none ko twabonye ko right lung nayo ifite ikibazo kandi twaba turi kubona
urabona in this case aho bitandukaniye gusa nuko ni type of cause, which cause before it was a opacity. Now it is pneumothorax. That's the cause, but it is that pneumothorax is pushing the mediastinum.
Okay.
The differences
none
are
se
the causes.
Muri pneumothorax nabwo tubona zari nuzo muri mediastinum shifting kuri affected side now.
Opposite kubera ko ni mass it's a feeling it's how do you call it? The air is filling the space.
The pleural cavity.
The pleural cavity with pressure. So it will push the rest.
Biragaragara.
Ikintu twakongeraho mwari mwavuze atumvishije neza nuko ni tension in pneumothorax. Iri severe enough to push the mediastinum.
Exactly.
None se buriya iriya left lung yo buriya ni nzima?
Nabisobanuye. The left lung, first of all, it has reduced the volume, urabibona ko yabaye ntoya.
Yego.
Kubera iki? Kubera ko iri compressed. The mediastinum yagiye occupying umwanya wayo yarayisunika iba ntoya, umwuka mwinshi ntabwo uri kujyamo.
Okay.
Niyo mpamvu ubona ari somehow white.
Heterogeneous.
Not heterogeneous n'ubundi lung ni heterogeneous ko barimo vessels na air, ariko it is somehow white kuko nta mwuka mwinshi urimo, yabaye compressed by the rest. Alright.
Turashishuka buhoro buhoro.
Bizagenda biza. How about this one? Sigaye iminota ingahe mbere? Iminota irayirukanse cyane.
6.
Mwakongeye iminota nka 20.
Ko twarushye.
Mwananiwe?
Atari.
Nka yanjye.
Na telefone zigiye gushiramo umuriro.
Telefone
zigiye gushiramo umuriro.
Ngaho ntacyo dukoresha itanu isigaye, nta kibazo, nta kundi nagira neza.
Ariko nabyo tuzabyiga.
Ni ngombwa jewe mba numva ngomba ko mugomba kubyiga paswe nk'umuntu ari mfite cases zigiye zitandukanye kugira ngo murebe. Tell me about this one. Tell me about this.
Lecturer, I see that on the lower zone of the lung, of the left one, there is somehow heterogeneous opacity. Yeah, and it looks like not much in lower zone of the left
Yes,
trunk.
that's what do you
Heterogeneous.
no. Type of the type of is
Okay.
it the airspace? Is it
Airspace.
interstitial?
It's
Mhm.
it's the
It's the
airspace.
airspace.
It's the airspace opacity. Iyi ngiyi niyo bita muri radiography ground opacity, because glass opacity yosobanuye it you can see that through it like it's all opacities are not, they don't have the same density as what you have seen. Sometimes some opacities are vague like this. You can even you can even overlook it and say it's normal. But this is pneumonia also. This is airspace. This is not pneumonia. This is consolidation. Opacity, ground glass opacity. This is the consolidation also. Okay.
Yes.
How about this? Rutayisire se we arahari Rora?
Yes.
Arafati se barahari? Kuzi ko Arafati ashobora kuba akwepa amasomo kandi ari sepe cyane ntabwo ari we. Hmm?
Is- um,
Ntajya kwipa ariko bamwiyamagana. None n'ubu ngubu se ari he? Ari he?
arahari.
Arafati ni aho ubundi Arafati.
Network mushyira
Mayamenya
Class imwe twese tuba projecting.
Are you projecting?
kirahagije kuri buri muntu.
Oya listen. Foto ntabwo ari nziza nayo.
Oya
Kanze nkohereza nimero zanyu.
Buri wese yagiye Ukuri turashaka kumenyana.
tuba twumva uri umuntu wa danje.
Wowe ntabwo uri umuntu watanje, wowe umuntu mwiza cyane.
Oya ntubyibereye.
Ntabwo ni umusivile, ntabwo ni umusivile. I'm not a civilian.
Rector nawe ifite igitekerezo. Ukorera he?
Rector ngo umudemobe.
Wowe ko ntabwo ni umusivile, mwambwa mwe ntabwo ni umusivile.
Ntabwo ni umusivile mwambwa mwe. Akuru umudemobe. Akuru umudemobe.
Ariko ntabwo nawe ndi umusivile mwambwa.
Kumeza subiza hariya.
Iki kibazo Eruine agomba kugikora, yanavuze amagambo menshi. Eruine
Eruine, please answer the question here.
Eruine
navuge rwose.
Iyo bigeze ku bibazo araceje.
Kandi
Eruine connection irahari turi kumwe ntubeshye.
Navuge rero.
Turakanye ntabwo yizeye.
Egera vuba ijwi riri kuvuga riranguruye.
Eruine no undi ukora amabije.
Yaranayikoze.
Ariko abantu bagiye bagira impano zitandukanye. Radiology ngo bayitsindereka. Nose bari muzi ko mwese mugomba gutsinda radiology kubera iki?
Oya twese nta nubwo twaba radiologist.
Exactly, ntabwo wabiteye na gato.
Eruine to answer this question. Eruine na
ibintu yamaje ntabwo bizi ahubwo bambaza utuntu tutubije. Ndi kubona
Okay, please.
Hyperclarity on the right lung of
harimo iki? I don't.
Clarity of the right hyperclarity of the right lung.
Hypersense of the right. Okay, I agree with you. Hanyuma
Paul Gomez.
Refreshing.
There is the left diaphragmatic elevation.
Ariko buriya muri radiology duhera ku bintu binini bigaragara cyane tukabona kujya ku bitoya.
There is left upper lung opposite.
Exactly. Left upper lung.
Right.
Left upper lobe collapse.
Upper lobe collapse.
How?
Because as it is seen for this image, there is air bronchogram on the which marks there is a pulling of the lower lobe of this lung and the middle lobe. Means maybe there is empty space on the upper lobe which causes this pulling.
Sorry?
General sinsobanukiwe.
Ntabwo nanjye numvise.
General natubwire.
Yitwa uwo ni mu general?
Uko bigaragara no ku ifoto.
Natubwire twumve.
Lecturer, he have talked about air bronchogram. If you see about in the middle zone of this lung, there is an air bronchogram.
Look, there is an opacity. There is an opacity in the left lung. Ariko ugiye kureba neza, it is silhouetting the margin of the heart. And the lower part of the lung is aerated here. Can you see?
Yes.
Can you remember the anatomy of the left lung? It has only two lobes.
Lung collapse.
There is nothing like lung collapse. This opacity, it has air bronchograms. Can you see?
Yes.
And there is no deviation of the mediastinum. There is no deviation at all.
Yes.
Yes.
There is no deviation. So, listen. Byanze bikunze urabona ko ari rero iyi ni consolidation of the left upper lobe. The upper lobe, the whole upper lobe is opacified.
Consolidated, yeah.
Yeah, the whole upper. This is now on the right side. It is hypercompensatory hyperinflation. Impamvu wambaza uti kubera iki the left hemidiaphragm yaba elevated. Niba hari consolidation the left lung, left upper lobe, urumva nta mwuka mwinshi, ntabwo ari guhumeka, aranababara buriya ntabwo guhumeka neza umwuka winjire on the left lung. That's the reason why if there is no inflation of the left lung, the left hemidiaphragm will now be elevated. Ikintu cyose muri radiology kirasobanutse.
Okay, lecture. You mean that the consolidation of the left upper lobe of lung will pull even the lower lobe and lead to elevation of left hemidiaphragm?
No, because iyo umuntu arwaye umusonga, what happens? Iyo umuntu arwaye umusonga, what happens?
There is destruction of airways, alveoli.
Exactly. Oya, no, iyo umuntu arwaye umusonga ntabwo ahumeka ngo atinya kwinjiza umwuka hariya ahantu ababara. You see? Mwumvise?
Yego.
Atinya kwinjiza umwuka hariya ahantu ababara, bigatuma igihaha cye ntabwo kijyamo umwuka wagira ngo kiba expanded. Wabyumvise?
Yes.
So niyo mpamvu ubona habayeho, it's like elevation of the left hemidiaphragm.
Okay.
Hanyuma the last one tukahita turekera aho ngaho.
Kuri fusion rwose.
Wayibonye ifoto nashyizeho se?
Nanjye ndumiwe ukuntu yaba yibonye.
Yegora ariko yaje noneho.
Amaze kuyibona kareda.
Tell me what it is.
Right upper lobe atelectasis.
Right upper lobe atelectasis.
Yes. Yes.
Iracyariho cyane nayivanyeho.
Bayikuyeho.
Ubanye ushaka kutwereka ya foto. Ariko iyi nayo turashaka kuyibereka.
Ya foto ndayibereka, ndabereka ifoto yanjye by the way.
That's good.
Ntabwo iragaruka.
Nayijyanyeho?
Yeah.
Ntabwo iraza.
This one.
Ntabwo iraza.
Share.
Yaje.
So what is this? Oya, ko mugiye kurangiza musubira inyuma cyane.
Is right upper lobe atelectasis because there is trachea.
Yes, please.
Side.
There is trachea. There is start by a big finding.
There is the upper right lobe opacity.
Okay, that's one. You start very well. Next. Opacity, how is it? Is it alveolar opacity? Is it interstitial opacity?
Alveolar opacity. Alveolar
opacity. It has air bronograms or not?
Yes, it has air bronchogram.
So, uhitumenya kwa consolidation. Is there any deviation of structures?
No.
Not. Even the horizontal fissure is not deviated. Normally, this is the pathway of it. The mediastinum is not deviated. So this is
right lobe pneumonia.
they are entirely like rubber pneumonia. Okay?
Yes.
Ndumva twarekera ahangaha. And tell me tell me now the next, what are you going to do next? Tell me as I'm looking my picture.
Arafati natubwira.
Kuko ndatekereza yuko jewe mumboneye one afternoon or one morning nabirangiza ibisigaye.
Sorry, Prof. Tomorrow we
Yes.
have no class. I think we can.
Dr. Louise nakinera ababwira.
Professor Pega ko arashaka kuvugisha.
It's for next week.
Azatwigisha next week.
That's my picture.
Umusirimu kweli.
Abandi umusaza umva rero umva listen.
Batya civilian.
I'm not civilian.
Nta mukobwa utera komentira.
Listen to me.
Yes.
So ejo tukomeze twigiye mu gitondere.
Why not?
Mu gitondo gusa dutangire ku saa 3 ariko.
Yego.
Nari bikabisa.
Musiba. Twaje kwiga. Nta kibazo rwose.
Okay, turabyemeranje. Ejo saa 3 turakomeza twige rero.
Yes.
Nta kibazo.
Dr. Louise yabwiye iki?
Next week.
Next week mufite mwanya.
Natwe twumva.
Ubwo hari ibintu bazimura.
Kubera iki atigishije this week kandi yagombye kwigisha this week?
Natwe byatu. Mutubarize.
Byaducanze.
No lecture. This week we have the dermatology. From Thursday.
No problem. Jewe ejo tuziga ibyanjye tubirangize nta kibazo. Bye rero umugoroba mwiza then.
Twumva gururukara. Sawa bye.
Ni inzobe cyane ndi umuzungu
Urata n'amafaranga.
Eruine nawe ugomba kumuvugisha kuri ya gahunda.
Louise anyoherereze Eruine niba Eruine.
Eruine.
Oya ariko nanjye nyine murebe ko mungenza da.
Humura Emmanuel uregere Eruine.
Eruine ariye ko atashyira ifoto ye kwanza tumurebe hano.
Nawe nayishyira.
Agire vuba nashyira ifoto ye vuba cyangwa.
Agire vuba turekoze bigenza.
Nanjye nyisharinge se.
Byavanye
watinze.
Uca abana.
Reka nanjye ndi umuntu w'umusani nkawe.
Ako lecture yavuyeho.
Lecture yagiye sha.
Nawe kiriho.
Bari kwivugana basha.
Nyamara rero bicara basanga hari.
Ngapfa kwidoha turebe ibyo ari byo.
Reka ndamwemeye. Zikayike igende.
Dore Ruine yagaragaye. Niziri
Eruine.
Asesha Eruine washyiraho kamera ubundi.
Ko ndashyiraho ifoto ye.
Nagire twigire.
Nagire
vuba bose bafungura amakamera yabo.
By the way, kugiye nigisha abantu ntazi ariko ubundi.
Twese rwose amakamera.
Twese buri wese.
Uyu muntu witwa Yora Gatsiri nafungure.
Nanjye ko ndi mu mwijima dushyizeho twese kamera byabona.
Oya wosa nijoro n'ubunini wiri guyishyiraho.
Okay, so have a nice evening. See you tomorrow morning at 9.
Nta kibazo
ndakora. See you lecture.
Jama.
Byashushe ba.
Twigire Kabgayi mwana.
Yome. Yakuryamurana niwe.
Yewe narindi.
muri kuri wifi niyo mpamvu muri kwidagadura.
Iby'ubuntu bitera ububwa mwana zigura interineti cyangwa urore. Wamurega so umurya hakariho. Ibintu byaciyemo mwana Yesu ari kugabura muri izi minsi. Gukora yikize.
Mujye box.
Wasohoka Salomo nabasohotseho gato twiganire.
Murahazi. Robert kuraho link. Ugasa seko n'abantu bari kujoininga karasi irangiye. Gaston ari he?
Ase sha mwavuye mwanganye n'iki murimo?
Umugabo waba presentingira nkagira ibintu bimwe mbaga ndi kubereka bijanye no kugira.
Wa mugani.
Ahubwo nigiye kuyobora ikiganiro mutuze basha.
Ngaho kijyane sha niba ari ikiganiro ushaka turakiguhaye. Kandi dupfa ibiganiro koko.
Gaston hari imana ari kukumva turi kumwe. Ariko kumva. Ariko kumva.
Gaston byanze ndakurahiye.
Ni fresh.
Ndabamenyesha yuko hari ibintu bimwe na bimwe ubu ngubu mpagazeho bonge ndi mu kabari.
Abyicareho ntare.
Niko bonge nibereye mu kabari mwana ndi kwitatamurira icupa.
Nanjye mfitiraho video no washa.
Inda nini tuyima amayira mani.
Turagashyira hera.
Inda nini tuyima amayira.
Kuko igira inama mbi bro.
Kugira inama mbi.
Ukaba umugaragu wawe.
Ukayitenguka ukayita ukisanga wabaye umugaragu we. Inda nini burya niyo mujura kuko ibishaka ibijyamo.
Niko. Ntabwo ariko kumva nambaye kuteri.
Meza.